Buongiorno, thank you very much, Benedetta. Sorry for the introduction. Good morning, everyone. As you already have seen, this conference is a special conference. This one, Fast Italia, like the Fast US, brings together clinicians, scientists, and families, and gives the real feeling of the need for moving forward with the research and development of treatments. It is my pleasure to be the chair of the first session. I'm not going to take much time in the introductions, so I'm going to ask, I'm sorry with the speakers that I'm not going to give the justice to their expertise. I'm just going to give a couple of words for each, and then we'll move on with the speakers in the interest of time. We're going to start with Dr. Lynne Bird. Dr. Lynne Bird is a clinical geneticist specializing in dysmorphology. She is the professor of clinical pediatrics at UCSD, University of California, San Diego, working at the Children's Hospital. She's the principal investigator in San Diego of a multi-site consortium that study Angelman syndrome at all levels, including clinical trials. She's one of the world experts in Angelman syndrome. Lynne, the floor is yours.
Thank you. Buongiorno. I'm really happy to attend my first Fast Italy meeting, and I greatly appreciate the invitation to come talk to you and to visit your marvelous city. So here is what we are going to try and accomplish in this talk. First, I will summarize the important milestones in the history of Angelman syndrome research. Then we will review the molecular basis of Angelman syndrome and the mechanism by which the paternal copy of UBE3A is silenced. We'll explain the mechanism by which ASOs work to unsilence the paternal allele of UBE3A. And ultimately, I'll briefly summarize the phase 1-2 trials, which you'll hear more about from other speakers. Here are my disclosures. I am a paid consultant to Ionis Pharmaceuticals as they develop their Angelman syndrome program. I've also been paid to do clinical trials in Angelman syndrome by various companies. It's been nearly 60 years since British pediatrician Harry Angelman described 3 children with a stiff, jerky gait, absent speech, excessive laughter, and seizures. He called them puppet children because their arms were upheld in flexion while walking as if suspended from strings. And the syndrome was called the happy puppet syndrome until the eponym Angelman syndrome was adopted in 1982. A lot has happened since that initial description of Angelman syndrome. In the 1980s, research began at the University of Florida by Charlie Williams and others to try and better understand the clinical features of Angelman syndrome. In 1987 was the first report of a chromosome 15 deletion that could cause either Angelman syndrome or Prader-Willi syndrome. In 1995, we saw the consensus diagnostic criteria published, and in 1997, the gene causing Angelman syndrome was identified as UBE3A. Very shortly thereafter, the first mouse model of Angelman syndrome was created. Just after we rolled into the next millennium, the first clinical trials in Angelman syndrome were started, using dietary supplements in an attempt to modify gene expression. In 2003, the National Institutes of Health Rare Diseases Clinical Research Network funded the Angelman, Rett, and Prader-Willi syndromes consortium. In 2006, the first patient was enrolled in the Angelman natural history study. All along the way, additional mouse models were developed, and in 2007, Van Rooyen reported being able to rescue deficits in the Angelman mouse by using a double mutant strategy. Based on that work, Wen-Han Tan started a trial of levodopa to treat Angelman syndrome, that being funded by the FDA. In 2011, Ben Philpott's group showed that it was possible to switch on the paternal gene using topotecan, and Ed Weber's group demonstrated gene therapy could partially rescue the Angelman mouse. In 2012, Baudet and others defined the mechanism of silencing of paternal UBE3A. We're not done yet. In 2012, a pilot study of minocycline was reported, which was followed by a randomized trial in Spain. Art Baudet, in collaboration with Frank Bennett, Frank Rigo, and others at Ionis Pharmaceuticals, demonstrated that an antisense oligonucleotide could unsilence paternal UBE3A in 2015. And later that year began the first industry-sponsored trial of gaboxidol by Ovid Therapeutics. In 2016, the Global Angelman Syndrome Registry began, and in 2018, the Italian patient registry opened. The same year, we saw the imprinting defect mouse model developed, as well as the phase 3 trial of gaboxidol. In 2020, the first phase 1-2 trials of antisense oligonucleotides began. In 2021, rescue of the Angelman mouse was demonstrated by infusing hematopoietic stem cells that had been transduced by a lentiviral vector. In 2022, Neuron Pharmaceuticals began a phase 1 trial of NNZ-2591 in Australia, and in 2023, Roche began a phase 2A trial of allogabet for deletion Angelman patients. In 2024, we saw a demonstration that prenatal ASO treatment of mice was possible, and Ultragenyx's phase 3 ASO trial began, followed closely this year by the launch of Ionis's phase 3 trial. All of this is to say that it has taken a huge global effort to get to where we are today, starting with astute clinicians reporting their observations, basic science research in many domains, longitudinal studies to document the natural history of Angelman syndrome, clinical research, and funding from both private foundations and government organizations worldwide. So let's go back to 1995, before the gene was identified, when the clinical features of Angelman syndrome were established based on deletion cases or clinically diagnosed cases. A group of experts came together and developed consensus criteria for the diagnosis, an effort that was led by Charlie Williams and Jill Clayton-Smith and others. Essentially, all patients had severe developmental delay that evolved to functionally severe intellectual disability, no speech, although the occasional patient might be able to utter a couple of simple words, movement disorder consisting of an unsteady or ataxic gait and tremors, as well as being constantly in motion, and a distinctive behavior profile of a very happy demeanor with frequent smiling and easily provoked laughter and being easily excited. Less consistent, but still quite frequent features were microcephaly, usually present by age 2 years, seizures that usually began before age 3 years, and a characteristic pattern on the EEG, which showed high voltage, an excess of 2 to 3 hertz brainwaves, the so-called notch delta, which we now know is a signature for Angelman syndrome. Occasional features included feeding problems and gastroesophageal reflux, excessive mouthing behaviors often accompanied by drooling, prognathic jaw, a broad mouth often with widely spaced teeth, eye alignment problems, a fair complexion, sleep disturbance, and a fascination with water. Some of the newer insights that have emerged now that we can diagnose patients molecularly and follow patients longitudinally include anxiety in a substantial proportion of patients, and constipation and other GI problems in many, as well as abnormal food behaviors such as food seeking, and an expansion of the milder end of the spectrum to include patients who have preserved speech. The changes that occur as individuals progress into adulthood were reflected in a publication by Ron Tiebert's group, showing that some problems, such as seizures and sleep, seem to improve in adulthood, but anxiety and movement problems increase and mobility can worsen. Gastrointestinal difficulties remain problematic. The clinical picture of Angelman syndrome has expanded, and we've been able to draw some correlations between phenotype and the molecular type of Angelman syndrome. There are 4 recognized molecular subtypes of Angelman syndrome, and just to be sure we all have the same level of understanding, I'm going to begin with a short genetics lesson. We have about 20,000 genes that are present in 2 copies in nearly every cell in our body, 1 copy inherited from each parent. The UBE3A gene is responsible for making the UBE3A protein, and it does so through 2 steps. First, the gene, shown at the bottom, is transcribed into RNA, which is the message that the body uses to build the protein. There's a complex machinery that accomplishes this transcription, and then another complex machinery takes the message and from it makes the UBE3A protein, a process called translation. For the vast majority of our genes, there is equal expression from both copies of the gene, which is actually the case for UBE3A in most tissues, except neurons. For UBE3A and a handful of other genes, expression happens only from 1 copy of the gene, depending on which parent the gene is inherited from, a concept that we call imprinting. For UBE3A, this imprinting happens only in neurons. So in the brain, UBE3A protein is made only from the maternal copy. The paternal copy is silenced at the transcriptional level. So no full-length RNA is made, and therefore no protein is produced. Once the protein is made, it then folds and organizes itself to become capable of doing its job. So what is UBE3A's job? It's involved in tagging aged and defective proteins with ubiquitin, shown here as these green blobs, which tell the body they should be degraded. There are multiple steps in this process, but UBE3A, shown here as the pink rectangle, is involved in the last step, where the green ubiquitins get ligated to the protein that needs to be gotten rid of, which is represented by the turquoise oval in this picture. Then the ubiquitinated protein is sent to the proteasome, where the protein is recycled into its component parts, and the ubiquitin is released to tag other proteins for degradation. So back to our 4 classes of Angelman syndrome. Anything that disrupts the function of the maternal UBE3A gene results in Angelman syndrome because the paternally inherited gene is silenced. The most common way to get Angelman syndrome, accounting for about 70% of cases, is to have a deletion on your mother's copy of chromosome 15 in the Q11, Q13 region. About 5 to 7% of cases are due to paternal uniparental disomy, where both copies of chromosome 15 come from the father. Another 5 to 7% of cases are due to an imprinting defect, where even though intact chromosomes are inherited from each parent, the maternal chromosome is given a paternal imprint and silenced. Lastly, about 15% of cases are due to a mutation in the maternal UBE3A gene. So even although all the genes are present and the imprinting is correct, the maternal gene has an error in it that doesn't allow it to function. And these latter three cases are collectively referred to as non-deletion Angelman syndrome. I want to emphasize that no matter the molecular type of Angelman syndrome, each has at least one silenced copy of UBE3A that could be activated. In this cartoon, the silenced copies are represented in green, and deletions and UBE3A mutations have one green copy, while UPD and imprinting defects have two copies to potentially activate. And we'll come back to this later. Much of what we have learned about Angelman syndrome in the recent past has come from data emerging from natural history studies. The one in the US was funded by the NIH Rare Diseases Clinical Research Network from 2003 to 2014, and later funded by the FDA, and now funded by the Angelman Biomarkers and Outcome Measures Consortium, which is a pre-competitive alliance of key stakeholders such as family organizations, industry, and academia. I'll take this opportunity to thank the investigators at all of the sites, but most importantly, the patients who came for visits at their own expense to expand knowledge about Angelman syndrome. This slide shows some data from the natural history study. This graph depicts the age of onset of seizures for individuals who have a deletion in red and non-deletion in blue. The peak age of onset is around 2 years for the deletion subtype, but closer to 3 years for the non-deletion type. For more non-deletion patients are having seizures that start after age 5. This is just one example of the variability of Angelman syndrome, which makes having a placebo control group essential in clinical trials. Multiple publications looking at genotype-phenotype correlations have resulted from the natural history study, and I am going to summarize a couple of decades of work by a lot of people in the next slide. Since the natural history study was funded from public money, the data have been freely shared with other investigators who had specific hypotheses that they wanted to test, as well as industry partners who wanted to understand the natural history of Angelman syndrome in order to plan clinical trials. So, generalizations that we can make regarding the various genotypes are summarized on this slide. Those with a deletion are more likely to have a classical presentation with seizures by age 3, microcephaly, and failure to thrive compared with the non-deletion group. Within the deletion group, the larger class 1 deletions present a bit more severe and more often will merit a comorbid diagnosis of autism when compared to class 2 deletions. Those with UPD are less likely to have microcephaly, almost always have a husky build, and many will have abnormal food behaviors, including hyperphagia reminiscent of Prader-Willi syndrome. Those with imprinting defects are often mosaic individuals who have both normal cells and Angelman syndrome cells, and they can function at a higher level, some even having the ability to speak in phrases. This slide shows some of the longitudinal data from the natural history study that was analyzed by a group at Roche. This is looking at the Bayley Scales of Infant Development, which is normed for typical children up to the age of 42 months and is used to assess individuals with Angelman syndrome of all ages, given their intellectual disability puts them in the range of performance of a toddler. The performance of the typical population is shown in gray, and the Angelman population is shown in red, deletion, or blue, non-deletion. A couple of things to note is how very flat these trajectories are, indicating that skills are acquired very slowly. Another thing to note is that performance in the non-deletion group is, on average, superior to that of the deletion group, with the blue lines almost always above the red lines, but there's certainly some overlap. We can see that the expressive communication is the most challenging area, with there being the biggest gap between typical individuals and individuals with Angelman syndrome. Lastly, there seems to be a plateauing of skills that occurs around 6 to 8 years of age, as measured by the Bailey. We all know that Angelman syndrome individuals continue to learn long after this age. This is from the same manuscript, now showing the developmental measures on the x-axis, including the Bailey 5 domains, the 11 Vineland Adaptive Behavior Scale domains, the preschool language, auditory, and expressive domains, and clinical severity scale, which is a non-validated tool that was created by the investigators of the first natural history study. On the y-axis, going upward, is essentially a z-score of relative performance. What this shows is that the average performance for the deletion groups, class 1 in purple and class 2 in orange, is below that of the other molecular types. There are minimal differences between the deletion classes, but on average, those with the larger of the two common deletions fare a little bit less well. Individuals with UPD, UBE3A mutations, and imprinting defects have higher performance. UBE3 mutations were divided in those who have truncating mutations, which are expected to produce no protein at all from the maternal allele, and missense mutations that might well have some residual protein activity. In most categories, the highest performance was seen in those with UBE3A missense mutations. As I said before, all molecular types of Angelman syndrome have 1 or 2 healthy copies of UBE3A that could potentially be activated. In order to devise a strategy to activate the silenced allele, we first need to understand how the silencing is accomplished. This cartoon shows chromosome 15 on the left, and on the right, it's been laid on its side with the region of interest magnified. This black arrow here means that UBE3A is being transcribed from the mother's copy of the gene. There is no transcription from the father's copy of UBE3A, and that block is accomplished by a long piece of RNA that's made in the direction opposite of normal transcription, called the antisense direction. This long piece of RNA is called the antisense transcript, or UBE3A ATS. So, can we get rid of the antisense transcript? And if we did that, would the paternal gene get transcribed and make some protein? Strategies to release the antisense transcript and free up the paternal gene to be transcribed are being investigated now. Exactly how does the antisense transcript keep the paternal gene inactive? This is a figure from a paper by Art Botet's group at Baylor, investigating the mechanism of UBE3A imprinting in mice. In this figure, the direction of the chromosome has been flipped, so UBE3A is being transcribed left to right. Up top, you can see the beginning of the gene with the first 13 of its 16 exons. On the bottom, you see that RNA polymerase II has begun to transcribe UBE3A from the paternal chromosome. And from the other direction, the long UBE3A antisense transcript is also being transcribed right to left. And when the two polymerases meet going in the opposite direction, this prevents transcription from continuing, and the full-length UBE3A messenger RNA is not made. At the moment, this so-called collision hypothesis is the leading explanation for the mechanism of repression of the paternal gene. So, How can we get rid of the antisense transcript? One strategy is to take advantage of the RNase H mechanism, which is already present in all of our cells. Ribonuclease H is a family of enzymes that hydrolyze RNA-DNA hybrids. Once an RNA-DNA hybrid is detected, RNase H cuts the RNA molecule apart. So if a small piece of DNA, an oligonucleotide, is generated which would be complementary to the antisense transcript, in other words, an antisense to the antisense, it will bind and form an RNA-DNA hybrid, and this would be expected to trigger RNase H to destroy the long non-coding transcript and potentially wake up the paternal gene. So in Angelman syndrome, the maternal gene is missing or defective, and the paternal gene is repressed by the antisense transcript. If an ASO targeting the antisense transcript is administered, the idea is that the paternal gene would now be freed up to be transcribed. So Art Baudet's group at Baylor, in collaboration with Ionis Pharmaceuticals, first showed in cultured neurons that you could indeed repress the antisense transcript, shown by the red lines going down, and increase protein production, shown by the green lines going up. And this was just as effective as using topotecan, which Ben Philpott's group showed could unsilence UBE3A. They then showed that you could do this in a mouse by injecting the ASO into the fluid-filled cavities of the brain, and the ASO gets to all brain regions, and the knockdown of the antisense transcript and the increase in UBE3 protein lasts for 16 weeks after a single injection. This, of course, laid the groundwork for trying ASO therapy in humans. They were able to show that 4 weeks after a single injection, contextual freezing behavior had been restored, but several other measures of performance, including marble bearing, open field testing, and accelerating rotarod testing, showed no improvement. The Angelman mouse on the right side, shown in the squares, is overweight compared to the wild-type mouse shown in diamonds, and those treated with the ASO, shown in triangles, had a reduction in body weight. These partial improvements in the mouse phenotype laid the foundation for taking ASO therapy into human trials. So fast forward to 2020, there are 3 companies that took this strategy into the clinic in phase 1-2 trials. Each trial uses the antisense oligonucleotide strategy, but they're all a little different. I'm going to give you a very brief overview because you're going to hear more about this in greater details from other speakers at this conference. The Ultragenyx study enrolled just deletion patients, while Roche and Ionis enrolled both deletion and mutation patients. The ages that were enrolled are shown there in the middle, and safety and tolerability was the primary outcome for all 3 studies. What we can tell you is that the safety profile looks quite good for all the ASOs. With the Ultragenyx compound, there was some leg weakness due to nerve root irritation, but this was seen only at the highest doses and was completely recovered after the drug left the body. Fever, vomiting, and ataxia were the most common adverse events seen in the Tangelo trial, and fever, vomiting, and cold symptoms were seen in about 20% of participants in the HALOS trial. In addition, all 3 trials showed some evidence of improvement in some areas over what would be expected from the natural progression of development that we know from the natural history studies. I don't have time to go through all of the assessments that were done to demonstrate these changes, but many of them were the same assessments used in the natural history study. And I know you're going to hear more about these assessments and why they were chosen from Dr. Barry Kravis and probably others. The Ultragenyx study demonstrated gains in cognition and receptive communication. The Roche trial showed gains in cognition, receptive and expressive communication, and fine motor abilities. And the Ionis trial showed gains in cognition and expressive communication. So we have still lots more to do to prove these therapies work, but we are on the brink of moving from the supportive therapies that have been the mainstay of treatments of Angelman syndrome to a future that includes potential disease-modifying therapies, such as ASOs, gene therapy, and gene editing, which you'll also hear about at this conference. I'd like to close by thanking all the wonderful families I've had the privilege of working with, to those who've participated in clinical trials and natural history studies, especially the family of this guy who's now an adult, as they were a huge force in getting Angelman syndrome clinical research off the ground and introducing me to this lovely community. Thank you.
Thank you. So it's only one part of it. How much do you think we need to model more of what happens in the children in lab models, so that perhaps we get a more comprehensive understanding of Angelman syndrome?
So the fact that individuals with UBE3A mutations look more similar to individuals with deletions than they do to typical children, I think is what makes most of us believe that UBE3A really is the main driver. And so if we can alter UBE3A activity, there might be some opportunity for improvement. I hesitate to use the word cure because I don't think we're there yet. We want to be there. But certainly there are other genes in the area of the deletion that must be important, because we do see differences between those with the deletion and those with the other types of Angelman syndrome. So clearly there are other contributions, and it's possible that a treatment for Angelman syndrome will look like a cocktail of different therapies. One designed to turn on the UBE3A gene, one designed maybe to modify the GABA transmission for the deletion patients that are missing several of the GABA-A receptor genes. So there may turn out to be a cocktail of therapies that will be needed to get the most improvement that we can see.
Any question from the floor?
If you can add some more details about class 1 deletion versus class 2 deletion. So what's the difference?
Yeah, so the difference is 4 additional genes that are missing in those with the larger class 1 deletion. They are non-imprinted genes. And we know they must have some effect because we can see subtle differences between class 1 and class 2 patients. So again, maybe a very personalized therapy for those with class 1 deletion would include all the things you're going to do for class 2 deletion, plus something that might address those 4 additional missing genes.
Any more questions?
What is the importance of time? Because there are trials 2 to 15, 2 to 50. In a 2 years old, the improvement would be a lot more. I don't know if you have some results about it.
So I think most of us who take care of patients with neurodevelopmental disorders believe that the earlier you start, the better. But at least in mice, there have been some very nice studies shown that you can rescue significant parts of the phenotype even when the treatment is done in adults. So I do think that the benefits may not look the same in patients who are treated when they're 20 as in patients who are treated when they're 20 months old. But I think we don't fully understand yet when the perfect time to treat is, and if there's a time beyond which treatment wouldn't help. We haven't defined an upper limit yet. We certainly don't know if treating even right after birth is enough. Maybe these treatments actually need to start prenatally. We don't know that yet. But my personal belief is that there can be benefits at any age.
No more questions? Thank you very much, Lynne.
You're very
This is
welcome.
wonderful. Thank you.